Hello, I'm Robert LeBoyer, Senior Biotechnology Analyst at Noble Capital. Our next presenting company is Eledon Pharmaceuticals, and with us is Dr. D.A. Groh and Paul Little, the CFO. The company is developing products for transplantation that modulate the immune system and prevent the rejection of solid organ transplants. The floor is yours, Dr. Groh.
Thank you, Robert, and thank you very much to Noble for inviting us to join today. I will be making some forward-looking statements during my presentation, so please read our disclaimers both here as well as in our publicly filed documents. As Robert just mentioned, Eledon is focusing on transplantation principally. We have a lead asset called tegoprubart, which is an anti-CD40 ligand that, as I'll go through, we are developing in a number of indications. To date, we have had over 150 human subjects on our drug, so we have quite a bit of safety, and as a result, we also have a good understanding of how it functions. From a capital perspective, we completed the last quarter with about $125 million in cash, which gives us sufficient funds to continue to operate to the end of next year. Now, during the next 18 months, we'll also have a number of important milestones. We're going to have data from our ongoing phase 1b study, which we expect to share over the summer, but perhaps most importantly for this year, we'll have data from our controlled phase 2 study in the fourth quarter of this year. We also expect to give updates on the other indications that we're working on, including islet cell transplantation and xenotransplantation. As here you have an overview of where we are in terms of development for tegoprubart. As I just mentioned, we are principally focused on transplantation, so we have three trials ongoing in parallel in kidney transplantation. We have a trial ongoing in islet cell transplantation, and we are ready to go into the clinic for liver transplantation. And those are all human-to-human transplants. In terms of animal-to-humans, or pig-to-human to be specific, so-called xenotransplantations, we've performed both kidney and adult heart transplants. And recently we reported data, although I will not go into details during this presentation on it, in pediatric heart xenotransplantation in non-human primate models. We've also completed a phase 2 in the past in ALS, although that program right now is on hold as we seek incremental financing, non-equity dilutive financing, to potentially advance it into a phase 3. Our drug tegoprubart is focused on the CD40 ligand, CD40 receptor pathway, the so-called CD40L. We inhibit CD40L, as you can see in the schema on the left-hand side of your screens. CD40L is principally found in two places: on the human body, on platelets, and on T cells. We have modified tegoprubart so that it does not bind to platelets and only binds to T cells. And when it binds to T cells, which are one of the primary types of cells in the human immune system, what it does is it inhibits the T cells from communicating with two other types of cells. Antigen-presenting cells, which are a whole class of cells that in the immune system show the T cells. The T cells a certain way are the police officers of the immune system. And so these antigen-presenting cells will show proteins or sugars to the T cells so that the T cells can help determine if if those, where they're seeing those antigens are self, in which case the immune system doesn't want to do anything, or foreign, in which case the immune system will activate. And then the T cells also interact with the B cells, and B cells are the types of cells that manufacture antibodies. So when the T cells are inhibited from communicating with the antigen-presenting cells, then they don't activate as much. And so this helps prevent the activation of the immune system. And then when the T cells don't communicate with the B cells, then that inhibits the B cells from activating and from generating antibodies. So that is one of the ways in which blocking CD40 ligands inhibits the activation of the immune system. This is quite different from what's historically been done using immunosuppressants, since historical immunosuppressants have focused on wiping out populations of white blood cells. Here, it's not what we're doing. This is a very targeted method to change how white blood cells are communicating. Now, interestingly, when we inhibit T cells from activating, some of those T cells will actually become a type of a cell called T regulatory cells, and those are the brakes of the immune system. They tell the immune system to tone down. And as a result, by one of the reasons why going after CD40 ligand we believe is so effective is that you stop the activation of the immune system, while at the same time you're helping to induce the toning down of the immune system. So said another way, we can help take the foot off the gas pedal and put the foot on the brake of the immune system. This is, as I mentioned, quite specific to CD40 ligand, as opposed to the receptor, which is found on the antigen-presenting cells, the B cells, and a lot of other cell types in the human body. We started by focusing principally on kidney transplantation, and that's because kidney transplant is the most common type of transplant performed in the United States and around the world. In the US, of the 45 to 50,000 transplants done every year, about 60% of them are kidneys. When we talk about taking tegoprubart or taking today's standard of care immunosuppressants, these are drugs that will be taken for the life of the organ or the life of the individual receiving a transplanted organ. Since the immune system doesn't go to sleep, it doesn't accept the transplanted organ. It needs to, the patient needs to take medicines for the rest of their life to make sure that their organ continues to be protected. Now, kidney transplantation is a large market from a dollar perspective, or even a person perspective, a patient perspective, but it's a very concentrated market, and in that way, it's quite rare disease-like. So if we look at the United States, there are about 25,000 Americans that get a kidney transplant every year. It's somewhere between 25 to 30,000, and approximately 10 times as many individuals are living with a functioning kidney transplant. That said, as we all know, there is a lack of organs to be transplanted here, so that there are about 100,000 Americans that are waiting for a kidney transplant. And here in the US, for every 5 Americans that we transplant, 1 American will die waiting for a kidney transplant. And one of the reasons for that, which we'll discuss, is that the average kidney today only survives about 10 to 15 years. And as a result, since the average age of transplantation is 51, people that are 20, 30, 40, 50, right, the majority of people receiving a kidney transplant will likely need multiple transplants during their lifetime if they are to live to an average age. Now, as I mentioned, this is a focused market, and that's because there are few centers in the US that actually perform transplants. Only about 200, 250 centers that are doing transplants. So while the numbers of patients are relatively large, the call points are not. And this makes it an attractive place for a smaller biotech like ourselves to focus, since we do not need the staff or ultimately the sales forces of a large pharma in order to cover all of these institutions. From a dollar perspective, kidney transplantation is part of a very large market looking at that includes kidney failure. The current standard of care, which is called tacrolimus, was originally under patent from Astellas. It peaked at about $3.5 billion in sales for Astellas, and in recent years, despite being long out of patent, it continues to do in branded revenues about $1.5 billion a year. As I mentioned, the average kidney only functions about 10 to 15 years post-transplant. And ironically, one of the key reasons for that, and this is what we're looking to address here, is the side effects of the standard of care medicine that we give today as the cornerstone immunosuppressant post-transplant. So that drug, which is called tacrolimus, is part of a category of drugs called calcineurin inhibitors. And calcineurin inhibitors are both directly and indirectly toxic to the kidneys. So CNIs, or tacrolimus, are directly toxic to the kidneys. They cause renal damage, kidney damage, renal impairment. They're nephrotoxin. They are indirectly toxic to the kidney because they also cause diabetes. It's called post-transplant new onset diabetes, as well as hypertension. And this is ironic since the two most common reasons why patients need a kidney transplant to begin with are diabetes and hypertension. Now, aside from these side effects, there's also other side effects that are caused by the CNIs, in particular CNS or neurological side effects like tremor and brain fog. And often it's these side effects that the patient themselves dislike the most. To give you a sense of the kidney damage that is being caused here, if we look at patients that are getting heart transplants, they typically will have healthy kidneys since they had heart disease, not kidney disease, but yet about 1 in 10 heart transplant patients will ultimately need dialysis or a kidney transplant after 10 years. Now, the reason why they need that dialysis or kidney transplant is not the heart disease, as I mentioned. It's because of the drugs, these CNIs that we give the patients, and that ultimately end up damaging their kidneys as well. Here we look at the relative importance of the toxic effects of CNIs over time. This is a graph showing why patients are losing their kidneys and what happens over a 10-year period. The green, blue, and yellow bars show you the kidneys that are lost because of an immune attack, and the red are kidneys that are lost because of the toxicity of the CNIs. And as you can see early on, particularly in the first year when kidneys are lost, it's typically because of an immune attack. But as time goes by, the principal reasons why kidneys are lost are associated with these CNIs. And our hypothesis is thus that if we remove these red bars, then the kidneys should do, the kidneys of the patients should do better. We are currently running 2 phase 2 studies in parallel with a long-term extension study as well. The phase 1b is an open label study, and that's a study that we use to learn about tegoprubart and to report out some data to the community as well as to investors. And then we have a phase 2 study. The 2 studies are quite similar in that what we're doing is using standard of care, except for removing the CNIs, the tacrolimus, and replacing it with tegoprubart. Our phase 2 has approximately 60 patients per arm. It's a head-to-head superiority study where we're looking to show superiority as measured by kidney function, so eGFR. And that is the study that will read out in the fourth quarter of this year. Our phase 1b includes two cohorts. A first cohort that is taking 20 milligram per kilogram of tegoprubart, which is the same dose that's being used in the phase 2. And more recently, we've added a 10 milligram per kilogram cohort, so a lower dose cohort as well. The study is designed to have up to 36 patients in total. So we'll look at the data that we've reported out in the past, but in order to do that, let's dive into what eGFR is. So eGFR, or glomerular filtration rate, looks at how well the kidneys filter, so how well they work. Normal is an eGFR of over 80. eGFR runs from 0 to 120. Less than 80 is abnormal, but it's really less than 60 that is considered to have kidney disease. When patients get below 20, then they are in kidney failure, and that's when they need dialysis or kidney transplant in order to survive. Here, we're looking at the latest and greatest of how well patients do after getting a kidney transplant. This was a study from a transplant consortium that looked at 5,000 patients followed over 6 years. As you can see on the left-hand side, regardless of whether patients received kidneys from a living donor, like a family member or a friend, or a deceased donor, such as someone that passed in a traumatic way and then donated their organs, post-transplant, their eGFRs peak in the mid-50s early on, within about the first 6 to 8 weeks. Subsequently, you can see what happens on the right graph over those 6 years. The red line are calcineurin inhibitors. That represents about 90% of this market, and almost the totality of those today are tacrolimus. And you can see how that red line goes down. And that's because of the tacrolimus eating away at the kidneys. Now, there are some other drugs that can be used in place of tacrolimus. Those drugs are not considered standard of care because they have their own issues. But as you can see here, the patients that received those drugs got to about the same eGFR level, but did not go down over time, since those drugs are not negative or do not have kidney toxicities. The reason we're using eGFR is that it is the best single factor in terms of how long a kidney is likely to function after transplant. So that the higher the eGFR, the more likely someone is to be able to keep that kidney longer. What you can see here is that improving eGFR by as little as 9 or 10 points for most patients will mean reducing the risk of losing their kidney, their transplanted kidney, over 10 years by 25% or more. So a 9-point difference is quite significant from a clinical perspective, and that's how we designed our phase 2 study. So our phase 2 study is 80% powered to detect a 9-point difference between tegoprubart and tacrolimus. Last summer, we presented updated data, interim data on our phase 1b study. Here is the data. We had 13 subjects at that time in the trial. The patients did not start all on the same day. So some patients, as you can see here, were only out 30 days. We had 13 patients that had made it 1 month, and 2 patients had made it over a year. Overall, the average eGFRs, if you draw a line, were in the high 60s or 70, which is quite above the 52, 53 that we just saw as the average eGFR historically seen with tacrolimus. So more than the 9-point delta that our phase 2 is designed to detect. In terms of the patient population, our patient population was interesting in that these were not patients that one might have expected to do better than average. In fact, overall, these were patients that were older, had organs from donors that were older, and had quite a bit of mismatch, so difference immunologically from the donors when compared to the average patient population. And then from a safety perspective, really what stood out here was that we did not see a lot of the safety issues that I mentioned earlier. So we did not see the high blood sugar or new onset diabetes, and we did not see things like tremor or an increase in hypertension, which are the side effects that are typically seen when a patient is taking tacrolimus. In terms of islet cell transplant, that could be a functional cure for patients with type 1 diabetes. We're looking at patients that have very high risk type 1 diabetes. These are patients that can get both very high as well as very low blood sugar levels, and so they're at the highest risk of side effects from their disease or complications from their disease. And in light of the time, I'll just show one slide to give you a sense of some of the data that we saw and that were reported in our first patients. Here you have a lady who had this very, very hard to control diabetes. She was 30 years old. To give you a sense of how hard her diabetes was to control, her daughters had found her unconscious from her diabetes on the floor of her kitchen before. In terms of insulin use, she was taking 60 units of insulin, so a hefty insulin dose, and yet she still had high levels of blood sugar, as you can see, and you can see that by looking at a blood marker called HbA1c, which is measured here. She got transplanted. Within 2 weeks of her transplant, she was able to reduce her insulin intake by 75%. And within 4 weeks of her transplant, she was off insulin. And soon after that, her HbA1c was normal. And so this lady was remarkable. And then in about 2 months, she went from having extraordinarily hard to control diabetes to having what has been described as a functional cure. And with that, Robert, I will turn it back over to you for any questions.
Well, thank you very much, Dr. Groh. 3 really interesting programs in kidney, islet cell, and you didn't even mention the solid organ or liver or the xenotransplantation. But just in the interest of time, the near-term milestones for the 1B data and the phase 2 data. Last year, we saw 13 patients from the 20 milligram dose. Can you give us any hints as to what to expect coming up in terms of number of patients or length of follow-up?
Sure. So historically, we've shared all the data that we have, and which is what we expect, what we plan on doing again this year. So we will show all of the patients in the 20 as well as the 10 milligram per kilogram group out to a year. The patients, after they're in the study for a year, go into a long-term extension study where they are, that is together with the phase 2 patients. So we will report out on the long-term performance at a later date. But we'll show you what we have for 20 mgs and 10 mgs. And so we're looking at over 20 patients worth of data.
Okay, and in the phase 1B, you have 20 milligrams per patient. And then in the phase 2, the active arm with tegoprubart also has a 20 milligram dosage. And even though the endpoints are, the primary and secondaries are different, some of them are the same.
So exactly. I mean, the primary thing we'll look at, and I think investors will look at as well, is eGFR. So how well the kidneys are functioning.
Yes. Okay.
If you think about it, that is what is predictive.
Exactly. That
Concern
was,
of how long those kidneys are going to do. So there are other things that we measure, for example, immune flares or immune attacks on the kidneys. Those are what rejections are called. Rejections are not organ losses. They're an immune flare, immune attack, or infections. But uh, the significance of those is when they then damage the kidney, and that would be reflected in eGFR. So that's why this is really looking at that's why that's the primary endpoint, and we believe the most important thing to look at.
okay. And you mentioned some of the immune flares. And one of the points that I think is worth mentioning is EGFR as a predictor of hospitalization. Can you talk a little bit about the side effects and the hospitalizations and cost of care for patients on the current standard of care versus the data that you've seen to date from the patients who've been treated?
Sure. So EGFR, to your point, is not only associated with long-term organ survival, it's also associated with hospitalizations in the first year. So the higher a patient's EGFR, the less likely they are to require hospitalization, and the less likely they are to require multiple hospitalizations. So as EGFR goes down, and intuitively it makes sense, right? As kidney performance goes down after transplant, those patients are more likely not to do well, and hence they're more likely to be hospitalized and to be hospitalized more often. So far, as I mentioned, from a side effect perspective, uh, for the key side effects where we believe we could differentiate ourselves from tacrolimus, so the hypertension, the brain fog, the tremors, et cetera. As I mentioned, we've seen that our rates were lower than TAC. In terms of side effects like infections or the immune attacks, the rejections, when we reported our data last year, we were in the same range from an infection perspective that they can typically be seen, as well as from the number. We had one rejection in the initial 13 patients that were in the trial.
Yeah, one of the things that stood out about the data was the patients have their EGFR restored up to the level of healthy adults, and going forward, they do better, the organs survive longer, and it reduces the cost of care. So
That
patients are better, healthcare system is better. This is a win-win for everybody.
Oh yeah, if we can get organs to survive longer, to your point, then it'll do two things. One is that it'll free up organs to go to people that otherwise would not have gotten them. Right? As I mentioned, 1 in 5 Americans waiting for that. For every 5 Americans that get a kidney transplant, one person dies waiting for one because they don't get an organ. So since 11% of the transplants or the waiting lists are repeat transplants, if we now reduce the number of repeat transplants because organs last longer, then more people will be able to get transplants. And that will obviously cut down on costs since dialysis costs over $100,000 a year.
Sure.
And similarly, it'll cost down and just the cost of the repeat transplants as well, and the related hospitalizations. So there's room here for an economic benefit as well as an important, really life-saving benefit.
Yeah, and just in the interest of time, the islet cell transplant program had some really incredible data allowing patients to be insulin independent when they had that rare brittle diabetes. And what can we expect going forward in terms of additional data, additional patients, and clinical trials? And if you could also touch on expectations for liver transplants or other solid organs,
Sure.
that
So
would be helpful.
for solid, we expect to, we've guided that we would share non-human primate data, so preclinical data this year. And then for islet cell, we've guided that we expect to have 9 patients transplanted at the University of Chicago. So,
Great.
and then we will report out, we expect to report out data towards the end of the year where we can share how those patients are doing.
Okay, terrific. All right, that brings us to our time limit. We could probably continue this for another hour because the data is that interesting and that groundbreaking. So I'd like to thank you for joining us. Paul, thank you for joining us as well.
Thank you.
And we
Thank you
look
all.
forward to following these milestones. So have a great day.
Thank you.
Thank you, Robert.